Here are the hallmark features of digoxin toxicity, focusing on the clinical presentation, electrolyte shifts, and the classic ECG findings. Digoxin toxicity creates a dangerous combination of increased automaticity due to intracellular calcium overload and decreased AV conduction due to increased vagal tone. Most common arrhythmia is premature ventricular contractions. Most specific arrhythmias are bidirectional ventricular tachycardia, highly specific, alternates QRS axis beat to beat, atrial tachycardia with block. The combination of ectopic atrial firing and AV nodal suppression is a classic hallmark. Other rhythms are junctional tachycardia, atrial fibrillation with slow ventricular response, and varying degrees of AV block. Digoxin effect versus toxicity. Therapeutic levels produce the digoxin effect on an ECG, which is not synonymous with toxicity. This includes the classic scooped ST segment depression or mirror image correction mark sign and shortened QT interval. Non-cardiac symptoms often precede arrhythmias and are frequently misattributed to other causes, especially in older adults with vague complaints. Gastrointestinal, earliest, anorexia, nausea, vomiting, and diffuse abdominal pain. Neurological, lethargy, confusion, weakness, and delirium. Visual disturbances, blurred vision, and xanthopsia, seeing yellow or green halos around objects, or a generalized yellow tint to vision. The relationship between potassium and digoxin is critical for diagnosis and management as they compete for the same binding site on sodium-potassium ATPase pump. The electrolyte dynamics of digoxin toxicity vary between acute toxicity and chronic toxicity. Typical patient of acute toxicity is either intentional overdose or accidental ingestion, while chronic toxicity is an elderly patient on long-term therapy with declining renal clearance. Hyperkalemia is seen in acute toxicity and is a prognostic indicator of mortality. On the other hand, hypokalemia precipitates toxicity in chronic digoxin toxicity. Mechanism: massive sodium-potassium pump blockade pushes potassium extracellularly in acute digoxin toxicity. In chronic toxicity, the concomitant diuretic use depletes potassium, leaving more pump binding sites open for digoxin and hence the toxicity in hypokalemia. Symptom onset is rapid in acute toxicity, predominantly GI symptoms early. While chronic toxicity it is insidious, neurological and visual symptoms often predominate before cardiac. Hypomagnesemia and hypercalcemia also increase myocardial sensitivity to digoxin and can independently precipitate toxicity. Management priority topmost is to discontinue the drug and stop any potassium depleting diuretics. Carefully replete potassium and magnesium in chronic cases. Avoid calcium administration for hyperkalemia if digoxin toxicity is suspected. Historically thought to cause stone heart, though modern evidence is mixed, it remains a standard precaution.